Bismillah ar-Rahman ar-Rahim. We are going to start the last session of the meeting. My name is Dr. Faris Haibani, and I'm honored to have the co-chair with me, Dr. Abd al-Hebi. We are going to start introducing the first speaker, Dr. Louis Liu. Dr. Louis Liu, he is a consultant gastroenterologist from the University of Toronto. He is a well-known figure in functional GI disorder, and he's going to talk about navigating the IBS. Dr. Louis, he has been with us for the past 2 days. He shared actually the sessions in the motility, GI motility, and he's a well-known figure in functional disorders. He has many publications as an author, as co-author. Dr. Louis. Dr. Louis.
Well, thank you very much for the kind introductions, and it has been an honor to be invited to speak to you today. And I have to admit that it has been a privilege to have the opportunity to train many of the very, very smart students and trainees that will come to our hospital and the university. And it's quite exciting for me to come here to see them grown up and leading the field in their expertise. When I was in Toronto, I see them wearing our traditional outfits. So I thought that when here, I have to fall within the culture. And my student become my teacher because in the last 2 days or few days, Abdullah has been educating me about the history, the culture, and the traditions of Saudi Arabia, and learn a lot about your kingdom. So this morning he gave me this, and I said that we have to wear this in my presentations. Thank you very much. So this is my financial disclosure, and the objective of the session today will be that I'm hoping at the end of the sessions I will be able to allow you to describe the epidemiological prevalence and the, I just want to time that, I apologize. The disease burden of IBS, and the cardinal symptoms of IBS that we need to think about managing these symptoms are in the four corners of the maze that I call that the ABCD management of IBS, which include abdominal pain, bloating, and then the domains of the functional symptoms, the constipation and diarrhea. At the end, I'm hoping to be able to develop regimens that's able to manage this patient and help them to get out of that darkness that they always experience and feel quite burdened by. The prevalence of IBS, this is the map that summarizes the prevalence that is between somewhere 5% to 20% or more. In Canada, 1 in 6 Canadians suffer from IBS, and it's accounts for about 6 million Canadians. If you look at Saudi Arabia, it is white. It's white doesn't mean that IBS does not exist. It just means that there has been no data to put the colors in the map. And as Dr. Majid and Dr. Abraham mentioned earlier, that with further research in the country, hopefully we paint some colors in here. I did do a quick search and find a few studies that looking at smaller subpopulations of the prevalence of IBS, and it has been astonishingly high. If we look at it in a subgroup that looking at the medical student, the prevalence in a more recent study is about 21% more prevalence in men than more prevalence in women than men, which is the same as the rest of the world. In a school teacher, the prevalence is as high as 40%, and 60% of those that report effect in the day-to-day work, and about 46% report that there is absenteeism, and half of those patients report that it's impacting their quality of life and ability to perform their life duty. So it is a burden, and with the further research understanding epidemiology, then you can define what the cost burden, and it is important for health policy maker or people who participate in that process to identify where and how you want to spend your healthcare expenditure. In the US, IBS is one of the top 10 most expensive diseases to manage, because they are occurring in the very peak young age of the population, somewhere between 20 to 40, which is the higher prevalence in the population. That is the high productive era of the life. And in Canada, looking at all the people on permanent disability, IBS account for 6% of the total population that is unable to work in our country. So it is a major health burden. Therefore, looking after them better, allow them to receive appropriate treatment earlier would help to decrease the healthcare dollar. And in Canada, just the direct measurable costs account for about 1/3 of all the healthcare dollar that we use. Total expenditure, direct measurable costs in Canada for healthcare disease, digestive health disease is roughly about 18 billion, and IBS is 6.5 billion. In addition to the missed work date, about 13 days of those that are unable to go to work or go to a healthcare appointment that account for additional 8 billion of productivity loss. So it is a major economical burden to us. But what is the burden to our patient? How do they feel, and what is it about their personal experience? 1/4 of the patient would tell that the disease is severe, that meaning affect their day-to-day activity. And if we ask them, I'm going to give you a cure right now, that you get rid of all your symptoms, the patient would willing to sacrifice, on an average, majority of pick 10 to 15 years of their life. On an average, roughly willing to sacrifice 12 years of their life. It's not too surprisingly, it is significantly impacting the quality of life. There's a high rate of absenteeism that we talk about from school, from work, and it significantly use our healthcare dollar. What actually bothering the sick patient the most, and why do I say the four corner of the maze, is abdominal pain and bloating, and followed by the functional symptom, constipation and diarrhea. Because if we ask this patient what are the most bothersome symptoms, abdominal pain and bloating always come to the top two. What's the cause of IBS? It's very difficult to give you one single cause. It is a very heterogeneous disease, and it is a constellation of spectrum of etiology that arise from it, arise in causing disease. The belief is that there is some form of predisposition factor, could be early childhood predisposition because of certain exposure, maybe some genetic background, with multiple challenges and tip them over the fence. Then there is an effect in study looking at change in the permeability or occult inflammatory changes or dysbiosis in the gut, leading to hypersensitivity. Therefore, normal physiological stimuli can cause significant symptoms in this patient to affect their care. The diagnostic criteria for IBS is a symptom-based diagnosis because currently there is no objective assessment. The Rome 4 criteria is what we use, and currently we have Rome 4. The concept of Rome Foundation's diagnostic criteria for functional bowel disease, it is a combination of regularity and chronicity of the symptoms that has intermittent in nature. It is a recurrent abdominal pain that relates to defecation. So if the patient do not have, if the patient's abdominal pain is not associated with bowel functions, meaning defecations and or change in stool or form, it is not IBS. It is some other form of abdominal pain, maybe functional abdominal pain or other underlying functional etiology or organic etiology that we need to think about. And if there's a regularity of 1 day per week over the last 3 months with the onset of 6 months, will allow you to make a clinical diagnosis of IBS. And then we further subtype them based on the Bristol stool chart that if they have hot lumpy stool more than 25% of the time, we call it constipation predominant, and the diarrhea is not a significant portion of time, less than 25% of the time, or it is not caused by use of laxative. Diarrhea predominance will be those that vice versa having watery stool more than 25% of the time and have less than 25% of the time is lumpy hard stool. And then they go in between will be what we call the mixed type. We keep talking about hard lumpy stool, and this is the Bristol stool chart that we use in our clinical practice, and I would say that I put it on my computer desktop. I show it to all my patients because it makes my history taking very efficient and very objective. It also allows my patient to have something to follow as I'm treating them. So type 1 and type 2 is associated with slow transit, and is the only validated chart that we will be able to apply very easily clinically. And then type 6 or 7 is rapid transit, or that there's significant water content, either a secretory component or underlying inflammatory component. So there is also a descriptive term. If you Google that, it comes in English and many languages, and I just find it. It also comes in Arabic, so you can also show it to your patient. You can put it in your phone, in your iPad, and your desktop computer, in your save your screen. So if quick. Okay. Now I know what people mean about the mouse. So now we have the concept of the whole spectrum of the functional bowel disease. Earlier in the day, I talked about chronic constipation. It's mostly looking at the stool consistent frequency and other associated symptoms such as straining and sense of incomplete evacuation or using digital disimpaction or maneuver. Now, if we couple that along with functional symptom looking towards your right, if the patient presents with associated pain with the defecation, then we think about irritable bowel syndrome, and then we think about either constipation or diarrhea, depending on the stool form. So the other things that I'd like to present to you is that in the old paradigm of teaching, that we always talk about IBS is a diagnosis of exclusion. So if there's one other thing that I want you to remember from this session is that IBS is a diagnosis of positive diagnosis, that what I'm trying to convey is that we want to get away the concept of diagnosis of seclusion to empower the clinician to able to make a positive diagnosis. If we do an adequate history and physical examination, the physical examination will include digital rectal examination. I do that to look for pelvic floor dyssynergy in those patients who have chronic constipation. In appropriate patient in fecal incontinence, I would do a digital rectal examination, diarrhea predominance, I would also do a digital examination, particularly if they have associated fecal incontinence, because a patient could have retained stool dyssynergic defecation and have separate incontinence or frequent loose stool that is overflow diarrhea type concept. We recently submitted papers now is impressed looking at the association with a strong sense of urge and a prolonged straining with a likelihood ratio of dyssynergic defecation of 7.7 for therefore that appropriate history and physical examination will allow you to identify those patients of major concern. The history also would look at warning signs. The warning signs including new onset of symptoms in advanced age, the age definition is over 50, and or any signs of bleeding or concerning history of cancer or underlying organic disease, personally or family history, or abnormal blood tests. In terms of the basic blood tests that I would do in my patient with irritable bowel syndrome, I'm quite pleased to see that the first prize winning of the abstract is looking at the celiac disease, the iceberg in your country. Celiac disease is very prevalent. It's one of the most prevalent genetic disease that we could identify, and it's much more prevalent in patients who has irritable bowel syndrome. So I encourage you to think about that, to look for it in your patients, and it would apply to both constipation and diarrhea. For the diarrhea component, I would also look at infectious etiology. For both spectrums of IBS, I would also look at TSH. Constipation, I would look at calcium. And in my diarrhea component, if you can assess to that, you can do a fecal carboplectin, or at least look at inflammatory markers such as CRP or ESR. The other investigation will be based on what your predominant symptoms and the radiographic investigation as necessary. The reason to make a positive diagnosis is that most of these patients that's now based on our literature is that they suffer from 5 to 10 years before we make the diagnosis, therefore appropriate therapy can be offered, and also educate and reassure the patient. Otherwise the patient continues to get worried, to try to see more doctor to find the cause of why they have this symptom, and then have a necessary additional investigation. Therefore, it costs our system, it burden our patient, it also reduces risk of unnecessary additional investigation. If we look at a snapshot of what happened in Canada, we did a survey on a population that 12% of this patient will require hospitalization because of the IBS symptoms. About 10% of those would go to see physician or seek medical care about at least 6 times, and 3% would go to see doctor almost every month or more. These are the treatment options therapy that you could offer to your patient with irritable bowel syndrome with constipation predominant. The two that recommend strongly will be linaclotide and lubiprostone. You have been eloquently presented by Dr. Sad about using the specialized diet, psyllium, and also probiotic in managing this patient. But I also want to highlight that if you look at the quality of evidence, the antidepressants also have good, high quality of evidence similar to linaclotide. However, the recommendation is weak. It is weak not because we don't have good evidence. It is weak because it is based on acceptability of our patient and the side effect profile, and that some patient would think that you think that is all in my head. So it requires education and the patient understand the underlying pathophysiological cause of the symptom. Therefore, the patient will be receptive to take antidepressant. And if they have predominant pain, I will use tricyclic. If it's not, then if they have underlying anxiety and constipation or anticholinergic side effect is a major concern, I will use SSRI. Linaclotide is secretagogues that activate the cyclic GMP, therefore that activate the CFTR channel, promote chloride shift, therefore sodium and water follow and go into lumen and increase water content, local distension, enhance local peristaltic reflex, and that's the belief mechanism of enhanced motility, but it is not a prokinetic agent. It also go to the other side, again, on the opposite sides of the lumen and decrease afferent sensory perception. Therefore, it also improves in pain. In this treatment algorithm, we propose in any patient who walk in with constipation after history and physical rule alarm symptoms and assess the secondary cause to remove the secondary etiology, then you can subtype them. And if they have associated functional symptom with the constipation, I want you to focus on a column that we talk about the irritable bowel syndrome with constipation predominant. The first treatment options for us in our country will be linaclotide because of the dual effect of improving bowel function as well as improving abdominal pain. If the patient if the patient have ongoing residual symptoms of constipation, then we would increase the treatment option as if the slow transit using osmotic laxative and or stimulant laxative on a PRN basis. They may need rectal therapy if the sense of urgency and effective evacuation. If the patient has predominant functional symptoms such as pain or anxiety, I would suggest that you can use additional SSRI or or tricyclic antidepressant to manage abdominal symptoms that has been demonstrated effective in randomized controlled trial. If you are able to assess psychotherapy or psychotherapists to able to provide cognitive behavioral therapy, hypnosis, or relaxation therapy that has also shown to be effective, again, patient reception and accessibility is important. I want to quickly go over the diarrhea predominant. It occurred in about 1/3 of our patient population, and not too surprisingly, the symptom profile this patient complained will be diarrhea and predominant. But I would like to also emphasize the importance of the sense of urge and fear of fecal incontinence, although only occur in about 1/3 of our patients, and that's what significantly affects the quality of life and make them worry, unable to go to work or unable to carry through a meeting because of the fear of incontinence. If you look at the treatment options, that I believe that Imodium loperamide can be used, and when we use it on a PRN basis. The concern is the narrow therapeutic window and the patient get rebounds, abdominal pain, and constipation. Antispasmodic can be used, and generally I will use it for colicky abdominal pain, and generally would also use it on an as-needed basis. Tricyclic antidepressant will be the drug of choice for me before I have the advanced agent because it has both anticholinergic side effect and also pain profile. Although that it is recommended weekly, we do have good evidence. Again, the reason it recommended weekly is because of the acceptability and side effect profile. As I mentioned earlier, that we manage the functional abdominal symptom using dietary modification. I think Dr. Ed mentioned that yesterday very eloquently and comprehensively present to you 3 studies. I summarize it as follows, and the concept is that when there is dysbiosis or that when this patient have fermentation, increased gas and electrolyte or fluid secretions into lumen, that it is physiological. Physiological to us, it doesn't cause symptom, but when patient have visual hypersensitivity, it would cause increased symptoms. My general approach was that before I advance to the low FODMAP diet, I would use the NICE modified diet or the IBS conventional diet, depending on the patient's acceptability and interest. And if they have ongoing symptoms, then I will use the low FODMAP diet. It also mentioned low FODMAP diet the other day, but whenever we mention low FODMAP diet, you have a headache because it sounds very, very complicated. If you look at the list of food that they need to avoid, is very large number, and your patient also get very nervous and stressed because how can I remember all these things when I go shopping? There is an app. I use this app almost all the time, and you can download it if you have an iPhone or Android. It works on both platforms, and it's developed by Peter Gibson, the original investigator who developed the FODMAP diet. It's from Monash University. It's non-profitable, and it explains to you what it is about, what is the low FODMAP, and why is it causing symptoms, and it also have a recipe to help your symptom. The interesting thing is that if you look at each category, it is like a traffic light. So what it means is that the green light is the patient able to eat, and the red light is something can avoid. If it's yellow light, it's something that they could have some if they're really interested. So they can go to the category to make it much more easier and manageable and save your time if you don't have an expert dietitian in your clinic. I want to make sure that you remember one thing when you use low FODMAP diet is reintroduction. There's been study looking at that if it is not a diet that you're able to consume chronically in the long term because there is an associated dietary deficiency. The probiotic was summarized yesterday. I don't use it to improve abdominal bowel function in terms of frequency and consistency, but has been shown to improve abdominal symptoms. The therapeutic trial will be about 6 to 8 weeks. If they improve, they continue. If it's not, we stopped. Peppermint oil was mentioned yesterday as well, and the number to treat is 3. It is important to think about that it also only mainly works as a smooth muscle relaxant. The new formulation is sustained release, would help to decrease the spastic type general abdominal discomfort, but has not been, in my practice, significantly helped to regulate the stool consistency and frequency. The advantage of that it has a very rapid onset of action. Your patient will feel and know that whether it is effective within a few days. So if your patient uses it and it doesn't work by about 7 days, you can basically ask them to stop. The last two options will be iloxapril and rifaximin, and they both recommend strongly. And you can use rifaximin in your country here on an off-label use, and iloxapril, I believe that is not available, and it is available in our country. That it is a peripheral mu opioid, makes receptor agonist and antagonist. There is one agent you could consider using, and it is off-label, and it's available to you, is Ondansetron. It has been studied in an IBS-D population. It has shown to improve consistency, frequency, urgency, and bloating, but it really does not help pain. So if you want to control pain, it is not the right medication, but if you want to improve some of the other associated abdominal symptoms, it is reasonable to use, but of course it is off-label. These are the two studies that you can get later that I can send you the slide if you're interested. In terms of the spectrums of options that you could use, if we think about the diarrhea, you have an option of medication. Constipation, you have a list of medication, and so is abdominal pain. But if we want to choose a medication that covers predominantly for the patient of IBS-D will be constipation and abdominal pain. Linaclotide will be the most reasonable choice, and I have been using it quite frequently, and it has been quite effective in my practice. For the IBS-D, the most reasonable, if you look at the evidence available, will be iloxapril, the mixed opioid receptor agonist and antagonist, and again, it improves both abdominal pain and diarrhea. If I look at bloating, we talk about the diet, and we also talk about probiotic, and rifaximin also in a subset analysis also improve bloating in the patient with diarrhea predominant. This will be just a listing of all the treatment options for abdominal pain, bloating, constipation, and diarrhea. The important thing to think about that, as what is discussed yesterday, is that it is very important to manage your patient expectation, educate them, and if you could, have a multidisciplinary approach involving dietitian and psychiatrists or psychologists, therefore that you have better treatment success. My last slide will be that to emphasize the importance of patient-physician relationship in managing patients with IBS. It is important to validate and reassure your patient and educate what is the acceptable and normal bowel function to make sure that you address the concern why they're coming to see you and what is worrying them. and make sure that whatever agent of choice that we're using, the trial is adequate and we use it appropriately, and manage the expectation, because many of those agents that I present to you do not have 100% improvement and complete resolution of symptom. Most of them will be about 75% of the time or 50% of the time improve 50% to 3/4 of your symptom. So you need to know which agent and how much it is going to be improved for what symptom. And the reason I have a long list of medication is that I generally do not pick exactly which agent I'm going to ask my patient to use. I tell them these are the options, this is what I can help you to manage with, and they are going to engage and participate in the selection process, what they think will be effective. Because if they are part of the decision process, it will be more effective and they're more accepting, and it will also align their expectation and their belief, thereby it will optimize your therapeutic outcome. And thank you for your attention.
Okay, thank you, Dr. Liu, for the informative lecture. I know 20 minutes is not really enough for IBS, but thank you for sticking to the time.